Hello, and thank you for your attention during this video introduction to the new NEAR4PEM pre-intubation checklist. My name is Robin Wing, and I'm a pediatric emergency medicine attending at Hasbro Children's Hospital, affiliated with Brown University in Providence, Rhode Island. I'm also co-founder and co-chair of the National Emergency Airway Registry for Pediatric Emergency Medicine, or NEAR4PEM. I have no commercial financial disclosures. This work is funded through a Rhode Island Hospital Injury Control COBRA grant. For those of you that may not have heard of NEAR4PEM, I'll start with a quick introduction. NEAR4PEM is a rapidly growing international multi-center group that collects data on pediatric intubations in the emergency department and is working to collaborate on evidence-based improvement efforts in emergent pediatric airway management. We now have 17 pediatric EDs in the US, Canada, and Japan submitting data to the registry. We're currently recruiting and are onboarding representatives from close to 20 additional sites. The objectives for today's sessions are as follows. First, we'll discuss the risks associated with pediatric intubation. Next, we'll examine risk reduction strategies through existing quality improvement initiatives to improve safety of pediatric intubations. Then, we'll introduce and familiarize you with the newly developed NEAR4PEM pre-intubation checklist. Finally, we'll discuss the implementation of this checklist in your pediatric emergency department and help you understand your role in optimizing safe intubations in your PEDS ED. Let's start with a brief clinical case discussion. A 6-month-old girl with suspected genetic syndrome presented in respiratory distress due to viral illness. Over 30 to 60 minutes, she progressed to respiratory failure. BiPAP was started, but failed due to poor mask fit. The patient was found difficult to bag mask ventilate and intubate, leading to severe hypoxemia. An airway emergency was called and the patient required emergent tracheostomy. What if we could rewind time and do that case all over again? Could we have identified the risk of a potential difficult airway, had a plan for escalation of support, notified the PICU, anesthesia, and/or ENT early, transferred to the operating room for airway management, modified the intubation plan based on risk, utilized a timeout for situational awareness of the team? As this case and so many others demonstrate, tracheal intubation of critically ill children presenting to the emergency department is a life-saving but challenging procedure. A recent NEAR4PEM study revealed that about 1/4 to 1/3 of intubations in tertiary PEDS EDs led to adverse airway outcomes, or AAOs. These AAOs include all of the following. The size of these are proportionate to their frequency and occurrence and include hypoxemia, mainstem intubation, esophageal intubation, severe hypotension, emesis, cardiac arrest, epistaxis, dental or lip trauma, dysrhythmias, airway injury, pain or agitation, and laryngospasm. This study has validated prior small studies and revealed that the first intubation attempt is unsuccessful in over 1/4 of pediatric intubations in the PEDS ED. We know that multiple attempts are associated with adverse airway outcomes. So, we must ask, how do we mitigate these risks? Quality improvement efforts using airway management checklists have been associated with improved outcomes for children undergoing intubation in the pediatric and neonatal intensive care units. These improved outcomes were noted to be sustained over time. In this PICU study at NEAR4Kids sites, pre-intubation checklist use significantly reduced the likelihood of having an adverse intubation event in 2 follow-up time periods by 17 to 37%. In the NICU setting, a standardized checklist for intubation helped to result in a 10% absolute reduction in adverse events in intubations that was sustained. So this begs the question, can't we use those ICU checklists in our PEDS emergency department? Unfortunately, the answer is no. We've actually tried, and it doesn't work well. As I'm sure you all know and appreciate, the emergency department setting has unique features that distinguish both its patients and practices from intensive care settings. Compared to ICUs, the management of critically ill and injured ED patients requires rapid team formation with minimal preparation time, many times including team members who have not previously worked together in this capacity. Patients requiring intubation in the ED are older and have a higher proportion presenting with shock physiology. They also have different indications for intubation, including more neurologic indications and patient status post-trauma. Intubations in the ED are more commonly performed using video laryngoscopy, use different approaches for sedation and paralysis, and are more frequently attempted by trainees. Patients often arrive to the emergency department with little or no notice and without prolonged NPO intervals. Given these differences, existing airway management checklists from the PICU or NICU settings are not directly applicable to PEDS intubations in the ED. Patients requiring intubation in the ED will benefit from a pre-intubation checklist designed for our unique practice setting. While some institutions have filled this gap with a locally created checklist, NEAR4PEM has created a standardized tool for PDD use, incorporating feedback from national airway experts and insights from human factors specialists. The NEAR4PEM checklist has undergone rigorous development and testing. Its framework is standardized across the collaborative, yet it allows for customization to meet the needs of individual institutions. The goals of the checklist are to facilitate a shared mental model so that all team members have a clear understanding of their roles, expectations, and critical steps. To decrease cognitive load, allowing providers to focus on the patient rather than remembering each task. And to standardize care so that every patient receives the same high-quality care during this high-risk procedure. Over the past 3 years, NEAR4PEM used rigorous and multifaceted methods to design the checklist. This approach to checklist development included a modified Delphi approach to select checklist items, followed by human factors usability testing to optimize the design and create a prototype checklist. Then we conducted mixed methods simulation-based usability testing and human factors heuristic inspection to create a checklist that is made to align with the clinician's bedside workflow. It was carefully designed to balance comprehensiveness and utility while not being overly prescriptive or time-intensive. Let's walk through the final product to familiarize you with the checklist and its intended use. This is the NEAR4PEM checklist. The checklist is proposed to be used prior to all intubations in the PEDS emergency department, except for patients in cardiac arrest. It's designed to be read aloud to facilitate a shared mental model with the entire team. However, we recognize and expect that all of these preparation steps are actually happening simultaneously. Team members do not need to wait until the leader reads an item on the checklist prior to completing the item. Lastly, it should be completed entirely prior to the intubation procedure. This checklist has been customized with edits specific to your site-specific practice and site preferences. If you have comments or suggested edits for your PEDS, please discuss them with your NEAR4PEM site PI. We want to hear from you. We're going to take the next few minutes to familiarize you with the different sections of the checklist. The first section outlines our patient assessment and plans. Patient positioning optimized. Pre-oxygenation and apneic oxygenation plans discussed. Hemodynamic risks considered and plans discussed. For example, hemodynamic supporting medications and CPR preparations such as the defibrillator prep. Difficult airway, including C-spine immobilization, is considered and plans are discussed. Finally, institution-specific backup team been contacted. The next section reviews necessary personnel. First, has the airway proceduralist been identified and limits on attempts have been discussed, including the number and/or duration of attempts? Has the backup proceduralist been identified? Is the respiratory therapist contacted and/or present? And other personnel as needed. This may include a C-spine holder. Moving on to the medication sections, where we'll ensure that our medications are ordered and drawn up as needed. First is vascular access functional. Sedative and paralytic are ordered and prepped. Hemodynamic adjuncts as needed. And post-intubation medication plans are set. The equipment section ensures that all the proper sized equipment is available and functioning optimally prior to the procedure. For airway equipment, we ensure suction is ready, laryngoscope is selected and tested for VL, DL, or both, Endotracheal tube is prepared, including correct sizes, the cuff is checked, and the stylet's in place. Rescue devices are identified and prepared as needed, such as NPA, OPA, LMA, bougie, and surgical airway equipment. And for monitoring equipment, we ensure the end-tidal CO2 is monitoring and ready, including our inline. Pulse ox is functioning, and the blood pressure cuff is cycling and on a different extremity from the pulse ox. And finally, the final time out. Confirm the team is ready to proceed. Invite final feedback and/or concerns. And proceed with medication administration. Now that you're familiar with the components of the checklist, let's talk about how we'll implement it in your PZD. NEAR4PEM is utilizing an implementation science-based approach to create an implementation package to assist your ED with checklist use, including this informational video. Each institution has convened a multidisciplinary team of airway champions to provide input on implementation and ensure a successful rollout in your ED. Your airway champion team has decided on an optimal location for your checklist. Please refer to the email from your site PI regarding this location. How will it be used? Prior to intubation, the team leader should read each item on the checklist out loud. They'll complete a timeout prior to the administration of medications for intubation. What is my role? As per usual with each intubation, every team member should complete your usual pre-assigned pre-intubation tasks. You do not need to wait for the team leader to read a task before completing it. Listen carefully to the team leader as the checklist is read aloud. Ensure closed-loop communication. When the team leader reads an item on your checklist that's your responsibility, be sure to feed it back to the team leader if that task has been complete, is in progress, or if there's difficulty or questions related to the task. And speak up if you're encountering difficulty with completing a task. Importantly, maintain quiet in the room. After intubation, the entire clinical team, including you, are invited to fill out a QR code survey to help us evaluate the checklist and its use in your department. If you have any questions, please contact your NEAR4PEM site PI or a member of your airway champion team. You might be thinking, how will we know if we're improving care? Your NEAR4PEM airway champion team closely monitors all intubations in your PZD. After the new checklist rollout, they'll also monitor checklist use. Checklist use and adverse events will be discussed at your local PZD QI committee. The team is also able to follow benchmarking data from other NEAR4PEM sites across the collaborative and monitor adverse airway outcome rates over time. After this video, we'll take some time to allow you to dive into the relevant literature. Then we'll end with some questions and a survey. Thank you so much for your time and learning about this new QI initiative. We look forward to your feedback about its use. Feel free to reach out to your local site PI or myself with any questions or concerns.